Tēnā koutou katoa. My name's Nicola Batossi. I am CEO of Fertility New Zealand, and it's my pleasure to welcome you here tonight to our webinar. Fertility New Zealand is a charity which has worked hard for the last 30 years to support Kiwis who are wanting to create whānau. We do this in a variety of ways. We have a range of information leaflets that are available through fertility clinics and on our website, a range of information videos. We have a helpline for inquiries, and we run an annual awareness campaign. In 12 locations around the country, we have support groups, meetings and seminars running. They're organised by an army of amazing volunteers. We also represent the voice of all New Zealanders dealing with fertility issues on a funding and policy level. So we encourage you to join us. If you're not yet a member of Fertility New Zealand, please do sign up through our website, which gives you access to our forums. You can opt to get email updates on groups near you, and also every membership that we have supports the advocacy work that we do. Please do reach out to us, contact us through our helpline, which is free, impartial and supported by a panel of experts, and we'll be really pleased to help support and guide you in whatever way we can through your fertility journey. So the format for tonight's webinar is a presentation of about 20 to 30 minutes. At the conclusion of the presentation, there'll be an opportunity for questions. Please go ahead and type your questions into the chat box for them to be answered on screen. So without further ado, it's my pleasure to introduce to you our speaker for this evening, Dr. Sarah Wakeman. She is a fertility specialist and also medical director of Fertility Associates in Christchurch. So I will hand over to Dr. Wakeman now. Thank you.
Thank you, Nicola. That's great. So yes, I've been asked to talk about polycystic ovary syndrome, and in particular in relation to fertility, and I'm very happy to do that. Polycystic ovary syndrome is something that a number of my patients deal with, and it's a common thing that a situation that we commonly deal with and treat people for as part of their fertility treatment. So it is, however, sometimes a condition that's misunderstood, misdiagnosed, or not diagnosed when it should be. Sometimes it's overdiagnosed, particularly in younger women. And so, I'm going to just clarify a few things about that and then focus a little bit on actual treatment relating to fertility problems and PCOS. So polycystic ovary syndrome, or otherwise known as PCOS, is a really common condition. It affects perhaps around 10% in different studies, somewhere between 8 and 13% of women. It is actually higher in some populations of women than that as well. It's an endocrine condition, which means it involves our hormone system, and the main sort of features or main things that you see are based around being resistant to insulin. Insulin's a really important hormone that we all need to live, and it's involved with processing sugar. And if somebody's diabetic and doesn't have insulin or is completely resistant to insulin, then that needs to be sorted out, or they can't continue to live. And the other thing that features that are based around hyperandrogenism, which means high levels of androgens or male testosterone hormones. Now, all females have some male hormones, testosterone, that's normal, but women with polycystic ovary syndrome, a lot of them will have higher levels, and that causes some of the symptoms and is related to quite a bit of what you can see. So it can be associated with quite a lot of metabolic features, and that means things like high blood pressure, diabetes, heart disease, strokes, problems with the heart and vascular system. And it is a condition with a number of different symptoms. So not every woman with polycystic ovary syndrome will have the same symptoms, the same complaints. They won't all present in the same way. And for some of them, symptoms can change quite a lot over time. So what somebody might have as a young woman compared to a woman in their 30s, 40s, 50s, that can actually change quite a lot. Sometimes that's in relation to having gained weight over time, or maybe having managed to successfully lose weight, but also age itself, will often change things as well. So this slide here, I know it's a little bit complicated, but it's just trying to show a little bit, because people often ask, well, what causes polycystic ovary syndrome? And it's like a lot of health conditions. It's not necessarily, there isn't necessarily a simple answer, but a lot of it is down to genetics. So a number of people definitely have inherited it, or have inherited a definite tendency to have that. If they then have end up in in certain lifestyle conditions, particularly if they gain weight and have an unhealthy diet, then the features associated, symptoms associated with polycystic ovary syndrome may show themselves. And women with polycystic ovary syndrome may often be aware that they have other female relatives that have PCOS, or if it's older relatives that may not have been diagnosed, but they may be aware that they definitely show some of those features. Male relatives may be more likely to be overweight, adult onset, older onset diabetes, heart disease, early heart attacks, things like that. So some people will have a very strong family history of those things. And then lifestyle factors like being overweight, not exercising enough, they contribute to bringing out many of the symptoms of PCOS for some of these people. Some people may have been exposed to higher testosterone levels and things when they were a little female baby, a little female fetus inside their mother, and that can predispose them to polycystic ovary syndrome as well. And then in the lower half of the slide, it shows that the higher androgen levels, higher male hormone levels that this group of women have, can result in the increased body hair, acne, so they're common symptoms. They can affect, it's part of what affects the ovaries, and means that regular ovulation may not occur. And when ovaries are sitting quietly and not ovulating, for some of these women, they have just a chronically slightly raised estrogen level, and that can cause basically precancer and even cancer of the endometrium of the uterus. So that's something serious that we have to look out for. The higher insulin levels that these women have is what predisposes them, or insulin resistance is what predisposes them to diabetes, and the more metabolic related things like higher risk of heart disease and stroke and those kind of things. And all of those things can contribute to a lot of psychosocial issues. So there's been a lot more research lately that shows very clearly that women with polycystic ovary syndrome do have a much higher rate of depression, anxiety, low self-esteem, poor body image, all of those, all of those things, and that it's important that we think about that and look at dealing with that as well as the other more obvious physical side effects. So diagnosis is important, because quite often we find that women haven't necessarily been diagnosed correctly. And it is important to make a correct diagnosis. So to be diagnosed with polycystic ovary syndrome, you need 2 out of 3 things. So there's 3 things, and some people will have all 3 of them, but you need 2 out of the 3. The 2, one of them is not ovulating regularly, and that's usually shown by not having periods at all, or having infrequent periods every 6, 8, 12 weeks, something like that. Very occasionally, people will have frequent bleeding or ongoing chronic bleeding and not be ovulating. The second feature is hyperandrogenism, high male hormone levels, and that can be shown either by raised testosterone levels on blood testing, or people may be quite symptomatic with a whole lot of acne and increased body hair. So it can either be symptoms or blood testing. And the third thing is ovaries that have a typical polycystic appearance on scan. And that's what the syndrome's been named after. And it's a little frustrating because that's actually probably the least important of the three features. And it's really important that, as I've put on the next slide, that in teenagers and younger women, that is actually not used as part of the diagnosis, because teenagers and younger women have many more eggs remaining in their ovaries. That's normal. We're all born with as many eggs as we're ever going to have, and that number just declines with time. So teenagers and younger women obviously still have a lot more eggs remaining in their ovaries than a woman perhaps in her late 20s or 30s has. And when you do a scan, you'll see a number of little follicles, which are just little round cystic areas, and it's really normal to see them in everybody's ovaries. Ones that you can measure on scan tend to be between about 2 and 10 millimeters in size, and it's normal to see a whole lot of those. So if you're younger with lots of eggs, you should actually have, or a number of people will have, ovaries that look like this. So this is where some of the issues with misdiagnosis come in, when a teenager or a woman of about 20 is told that, look, actually you've got polycystic appearing ovaries on scan. That doesn't mean that they've necessarily got polycystic ovary syndrome, but they're perhaps told that they are, or they hear that they are, and then, carry this around, and it can sometimes cause quite a bit of distress. So, there is actually in all the guidelines something now that says that if a woman is within about 7 or 8 years of her period starting, so that would cover teenagers and sometimes women's aged around 20, that actually an ultrasound scan, number one, shouldn't be done unless there's some other reason to do it, and number two, shouldn't actually be used as part of the diagnosis at that age. It's also obviously important in terms of thinking of high androgen hormone levels. Young women, perhaps, teens and even early 20s, acne is still quite a normal, common thing. So again, we wouldn't like to think that a 15-year-old with acne, that may well be quite normal for a 15-year-old, that really shouldn't be used as part of the diagnosis of polycystic ovary syndrome either. And that, that diagnosis should be, perhaps kept to one side and wait and see what happens. Family history can be a little bit relevant, particularly if you're looking at younger women who are perhaps almost a little bit too young to diagnose. But if there's clearly a family history of other women with polycystic ovary syndrome, lots of people perhaps who are overweight, have diabetes, that kind of thing, that might definitely make you more suspicious. And the other really important thing is that there are actually some other hormonal conditions that we need to exclude that can look like polycystic ovary syndrome. Most of them are quite easy to exclude with a few simple often just with a few simple blood tests, but it's like anything, it is important to make sure that all those things are checked. So what are polycystic ovaries, which is where the name of the syndrome has come from? Their ovaries, the diagnosis has changed over the years as scanning has got better. So ultrasound scanning has got more accurate. We can see more in an ovary now than we could perhaps 20 years ago. So the current diagnosis for a polycystic ovary is an ovary that has 20 or more small follicles per ovary that you can see on vaginal ultrasound scan. And in younger women, in women from perhaps about age 25 and more, most of them would have less than that to see, although some will still have ovaries that appear polycystic with lots of little follicles, but not actually have polycystic ovary syndrome. And they are originally called cysts, but they're not cysts in terms of being a sinister cyst or anything bad. They're just follicles, and each one contains an immature egg, and they measure about 2 to 10 millimeters in size. The actual egg is microscopic, you can't see that. And like I've said here, what's really important is that just because ovaries appear like this on a scan doesn't mean that someone has polycystic ovary syndrome. They need to have those, some of those other features. Like we said previously, it's 2 out of the 3 things. And as I said before, ultrasound is actually not recommended to be part of the diagnosis if it's within about 8 years of a woman's periods starting. So this is just a little diagram to show, you know, where our ovaries are. So, you know, vagina, cervix, uterus, and then ovaries. And in a normal ovary, or what normally happens to follicles in the ovary, is that, you know, they go through this process where they're very small, they gradually mature, and then a mature follicle releases an egg, which is picked up by the fallopian tube, and then after that it becomes a corpus luteum. It's still producing hormones, and if a pregnancy embryo implants and a pregnancy starts, those hormones help sustain the early pregnancy. In a polycystic ovary, what you have is lots of follicles that are, you know, at the stage where we can see them. They're big enough, 2 to 10 millimeters, but they've kind of, a number of them have arrested development, and there's more like that. And often you see, it's often described as a ring of pearls. You often see lots of them on scan that are around the edge of the ovary. Some of the time women will have ovaries that are like this, but they're still releasing an egg. One follicle's developing further and they're still releasing an egg on a regular basis. But others will have ovaries that look like this, and they may not be ovulating at all, or very infrequently. This is just a couple of vaginal ultrasound pictures showing polycystic appearing ovaries. So the ovary is the, you know, thing that's sort of roughly oval. Depends, they can be a bit of a variety of shapes, but they tend to be round or oval. And these little follicles, you can see, if you measured them, they'd be, you know, 2 to 10 millimeters in size, and there's lots of them, and they do tend to be around the edge. And if you counted, you know, there's probably not quite 20 just in one view through the ovary, but it's a bit like that's a 2D image. The ovary is obviously a 3D thing, and these ovaries would have, you know, more than 20 if you counted right through. So what are the symptoms of polycystic ovary syndrome? There's a variety of symptoms, but some of the more common ones are excess hair growth, particularly on the face, the chest, the abdomen, and people are often aware that perhaps they've got more body hair than their friends or other people in their family. You know, as you may know, there's different people do have different amounts of body hair, but, you know, women with polycystic ovary syndrome may notice that they have a definite excess. Sometimes for some women with quite high testosterone levels, they'll actually develop hair loss on the scalp, female balding, just like men can, you know, can get that typical sort of balding on the scalp as they get older. Acne, particularly if women are, you know, particularly if this is a problem as women get a little bit older, that's less normal and maybe a sign of polycystic ovary syndrome. With periods, they may well be irregular or absent, so not there at all. Women may notice little patches of darker skin pigmentation and skin tags. That they can be a sign of insulin resistance, which is associated with polycystic ovary syndrome. And the polycystic ovary syndrome can definitely give women an increased risk of developing impaired glucose tolerance, so not processing glucose well. And if that continues, they can develop diabetes, gestational diabetes, so when they're pregnant, diabetes in pregnancy. They may have altered cholesterol and lipids that put them at increased risk of heart disease and things as well. Cardiovascular disease, so disease of the heart and blood vessels that will often be shown with high blood pressure, strokes, heart attack. They can, as I mentioned earlier, develop cancer of the uterus, and that will normally be women who aren't having regular periods or aren't having periods at all, and there's just chronic long-term estrogen exposure without any ovulation and without any progesterone exposure. And as I also mentioned previously, there's definitely a much higher incidence of depression and anxiety. So how's polycystic ovary syndrome treated? The important message is that it's a condition that needs to be managed and the symptoms treated, but it's not something that's cured and necessarily goes away. Although occasionally we do see women who would meet the features for being, you know, meet the diagnostic criteria, but over time that might change and they may, you know, they may no longer meet those criteria 5 to 10 years later. And it's sometimes then a little bit difficult to know what to say if they did seem to have it and now they don't. But, you know, given the right conditions, if they gained a whole lot of weight or something like that, they may well find that they then have do start having those symptoms again. And that, as I said, the treatment does depend very much on the symptoms that a woman has and what issues she's having. Lifestyle management, so managing weight, exercise and diet are really important. Treating, if people are having a lot of trouble with acne and excess body hair, then, especially if they're younger, often the combined oral contraceptive pill is often the best treatment for that and has a lot of other advantages as well. If that's not successful, then often anti-androgens, so, things that block testosterone. And there are, for acne and hairiness, often also specific treatments, so if somebody's got really bad acne, particularly cystic, that sort of really deep cystic acne, then of course a Roaccutane may be beneficial. There's obviously lots of different hair removal techniques that may help people as well. If people's main issue is treatment of irregular periods, is their cycle and irregular periods or not having periods, then if they're not wanting to get pregnant, again, the combined oral contraceptive pill. Otherwise, it's important that they have regular courses of progesterone so that the lining of the uterus doesn't have that chronic long-term estrogen exposure without progesterone. And when they take progesterone and then stop, generally they'll get a period and get bleeding. If fertility is the issue, then fertility treatment, and we're going to talk some more about that. And it's also really important too that there's a long-term view and screening for those metabolic risk factors. So, checking blood sugar, diabetes, lipids, all of those things. And that's stuff that ideally should be done at a GP, by your GP, because it's long-term health management. So how does polycystic ovary syndrome affect fertility? That varies. So some women with polycystic ovary syndrome actually won't have any problems with fertility and any problems conceiving. They may have other features of polycystic ovary syndrome, but actually have quite regular periods and not have any difficulty becoming pregnant. The main issue, however, that a lot of women will have is with ovulation. And not ovulate regularly or not ovulate at all. So that will be shown with either no periods at all or irregular periods, often quite infrequent, very occasionally with prolonged bleeding that won't stop or very frequent bleeding. The other way that polycystic ovary syndrome can affect fertility is with weight. So if women are overweight, which a number with polycystic ovary syndrome will be, that higher weight and higher body mass index is also associated with a reduced chance of pregnancy independent of other things, and an increased chance of miscarriage. So, that's another good another reason why we do advise people to try and get their body mass index down if it's up. So there's a range of fertility treatments that we, may need to use for women with polycystic ovary syndrome. For people who aren't ovulating regularly and aren't having regular periods, then it's really based around what we call ovulation induction, which means getting people to ovulate. The first line treatment is Letrozole tablets, which I'll talk a little bit more about. If people are resistant to that, or if previously they've used it successfully, they may use clomiphene tablets, which are similar to Letrozole, but Letrozole has really surpassed clomiphene now. We may still use FSH hormone injections, which are the same injections that we use in an IVF cycle. And the two other options, which are used a lot less now, but still occasionally have a place, ovarian drilling, which I'll talk, and I'll mention all of these in more detail, and Metformin. And then the other main fertility treatment for women with polycystic ovary syndrome is IVF, and we'll talk a little bit about that as well. So Letrozole, and I put in brackets and clomiphene because it, is similar. It's a tablet treatment that people take usually between days 3 and 7 of their cycle. And some of the advantages are that it's cheap. It's just a prescription charge. It's very easy. It's just tablets, usually minimal side effects. We would usually suggest that people have the first cycle of treatment monitored so that we can actually check that they are responding and that they do ovulate and release an egg or eggs. And the way it's monitored is with ultrasound scan, vaginal ultrasound scan, usually perhaps day 10 to 12 of the cycle, and we can see 1 or 2 follicles hopefully developing and getting bigger. Bigger than that, bigger than those smaller ones that are 2 to 10 millimeters. We want to start to see 1 or 2 that are perhaps 12, 14, 16 millimeters developing. And when that happens, then generally the woman will go on to ovulate, and we would check a progesterone level after the scan to make sure that the woman has ovulated, and obviously advise her to be trying for pregnancy, to be having sex over that time. And what we're aiming for is to get women to start having much more regular cycles, closer to 28 to 30 days. Sometimes they'll still be a little bit longer at 35 days, but, we want them to be aiming for 1 ovulation per month, and that will give them a much better chance of pregnancy. Some women, if that's not happening on the first dose, we may need to increase the dose to achieve this, and there will be a few people who we go through the 3 or 4 doses, keep increasing, and they're still not responding, and that's when we might try clomiphene. So there'll be a few that respond to one and not the other, or try some other things. Letrozole compared to clomiphene has better pregnancy rates, less side effects, and less risk of multiple pregnancies, so more likely that you'll just produce 1 or 2 eggs and so have a lower risk of multiple pregnancy than with clomiphene. So there are 3 good reasons to use letrozole over clomiphene. And this slide here, it's not perfect, but it just is trying to sort of show how these medications work. So the letrozole is what's called an aromatase enzyme inhibitor. So it prevents estrogen production in the ovary. So it makes the body think that estrogen levels are remaining low. And so the pituitary gland in the brain pushes out more FSH hormone and stimulates the ovary more. And hopefully that allows 1 or 2 larger follicles to grow. Clomiphene is similar. It actually binds to the estrogen receptors, but it has a similar effect. Both of them are basically tricking the body to think that there's less estrogen and telling it to, not giving it the negative feedback that estrogen's there. So it's telling the pituitary gland in the brain to make more FSH hormone. So if those things aren't successful, particularly if ovulation isn't occurring, then we may still use FSH hormone injections to get ovulation to occur. We tend not to use them an awful lot these days. We used them a bit more in the past. And they're daily hormone injections like for IVF treatment, but we're aiming to just get 1 to 2 follicles to grow and have 1 or 2 eggs available so that people can try for pregnancy naturally. Once we've got the follicles up to a big enough size where there should be a mature egg, we'd normally give a trigger injection to get ovulation to happen. The downsides of these are they're injections, daily injections, plus it's a lot more expensive than the tablet treatment, and it's a little bit more difficult to control the response. So somebody might not respond on 1 dose, we increase the dose a little bit, and suddenly they over-respond and they're making 4, 5, 6 follicles, so there's going to be 4, 5, 6 eggs, and we have to say, look, it's not safe to try because, we don't want you having quadruplets or something like that. That's dangerous. So 2 other things that are still used a bit, Metformin, so that's a common tablet treatment, and it used to be sort of considered a first-line treatment, and everybody with polycystic ovary syndrome would be placed on it. It still definitely has a role, but less role for fertility treatment than it used to. It reduces insulin resistance, so it's still used as a common treatment if somebody has impaired glucose tolerance or later onset diabetes, and it can make people ovulate more often, but really overall in big studies, all it achieves is 1 extra ovulation per 5 months. So that's not really the best, that's not a huge number of ovulations. For some women, they will find if they're overweight that they actually lose weight more easily on metformin. So if that's the case, then that's a good idea for them to take that. And it can improve acne and, hair, excess body hair as well for some women. So some women will find that they actually do get some benefits from taking it. We sometimes use it if some people haven't responded to letrozole or clomiphene and they've been resistant and we still can't get ovulation to occur. For some women, if you start metformin, they will then become more responsive and you may be able to get ovulation to occur after they've been on metformin for a month or so. The advantages are that it's very cheap, it's just a prescription cost and there's no particular monitoring required, so it's an easy thing to take, apart from the fact that for some women it will have side effects. It can have gut side effects and make them feel a bit sick and upset tummy sometimes. But if people continue with it, often those symptoms go away. And then the other treatment to mention is laparoscopic ovarian drilling, so that's surgery. Where keyhole surgery is done, and basically some small little diathermy burns are made to each ovary. And the idea is actually to destroy some ovarian tissue for women who've got large polycystic ovaries with lots and lots and lots of eggs in there. And by doing that, a number of them may then start ovulating regularly. But again, this is something that was used a lot when it was first, it was sort of in fashion for a while, maybe 15, 20 years ago, but we've now realised that actually it destroys ovary, and people ended up having it done at times when they didn't really have that many eggs in their ovaries. So it's very important that it's only done for women who really have evidence of a lot of eggs in their ovaries, and it can swap one problem for another. So no matter how carefully you do this, the fallopian tubes, ends of the fallopian tubes can sometimes stick down on the ovaries where those little burns have been made, and then you end up with tubal disease and less chance of pregnancy for that reason. So the other treatment is IVF. So particularly if ovulation induction hasn't been successful, or if somebody's been completely resistant, then they may well want to consider IVF. And IVF, in very simple terms, is stimulation of the ovaries with FSH hormone injections so that we do get multiple follicles to grow and multiple eggs. And these eggs are then fertilised with the sperm in the laboratory, and the fertilised eggs, the embryos, are then transferred one at a time into the uterus, each with a good chance of pregnancy usually at that point. With polycystic ovary syndrome, there can be some challenges with IVF. There's a higher risk of a condition called ovarian hyperstimulation syndrome, which is where there's been an over-response to IVF, and people can be unwell with very high hormone levels and end up in hospital. But the way we do modern IVF cycles, that risk has very much reduced. So there's a whole list of things we do with IVF now, which I've listed there, and I'm not going to talk about in too much detail at the moment, but they are things that significantly reduce that risk, so that the risk of severe ovarian hyperstimulation should be low if if an IVF cycle is well managed. And here I've just shown briefly, the sort of 6 stages of an IVF cycle. There's all the things to get ready, make sure everything's lined up, ready to go. Then there's the FSH hormone injections, which usually take, close to 2 weeks. Then there's the egg collection procedure, the sperm sample that we need, the semen sample we need the same day so that the eggs and sperm can go together in the laboratory. Then we have the fertilised eggs developing into embryos in the laboratory, and then finally we have an embryo transferred into the uterus. So, we would always prepare people with as much education as possible before they go ahead with IVF treatment. So with PCOS, the other really important thing is people, because it does tend to be, it's a chronic condition that people may well have, features of for their whole lifetime. It is really important that people take charge of it and try and manage it themselves, along with, in partnership with their GP. They may need, fertility specialist involvement if they're having trouble getting pregnant. They may need to see an endocrinologist if things are challenging, and they may end up seeing other specialists over the course of their lifetime as well. But lifestyle change is very important for a number of people, particularly if, being a larger body weight is part of their polycystic ovary syndrome. We do know that women with polycystic ovary syndrome, if they gain weight, that their symptoms will get worse. So trying to lose some weight is often helpful and will hopefully protect against some of the things that could happen in the future. And even 5 to 10% weight loss, so more modest weight loss, can make a big difference to symptoms and improve fertility quite a lot as well. I think for a lot of people, seeing a proper trained dietitian who's actually got a degree rather than someone who says they're a nutritionist with a certificate, seeing a dietitian who's got experience in treating women with polycystic ovary syndrome can be really helpful. There's no specific diet that anyone can say is definitely better than another, but there are a range of different diets obviously out there, and some people will find that one thing works better for them, other people may find that another thing works better for them. There's no doubt that losing weight successfully and keeping it off is very difficult, and it requires, a lot of effort and commitment. And for some women, if they really have tried everything and they have really high body mass index, then looking at weight loss surgery is actually a very sensible option. It can have fantastic results and, long-lasting results in women who've got high blood pressure, diabetes, a whole lot of things like that. Those conditions will often disappear as the weight comes off. So I think that's something that that for some people is well, is a very valid treatment. Regular exercise is important, and to be successful with that, it's about being accountable and also finding something that you enjoy. So some people will be, find that they can do regular exercise if they're accountable to a personal trainer. There's a lot of really good online exercise programs as well that provide support. Some people will enjoy swimming, cycling, dance, yoga. I think it's about trying to find what suits you rather than everybody just going to the gym. And psychological support is really key. As I've said already, it's well recognised that, low self-esteem, anxiety, depression are definitely increased amongst women with polycystic ovary syndrome. So actually addressing that and having, your GP be aware of that and help treat that, is probably going to contribute a lot to improving well-being and being more successful with improving symptoms. And in the longer term, it is really important to keep, weight under control, healthy lifestyle, and to have screening for the things that you may be at higher risk for, like high blood pressure, disordered lipids, diabetes. It's important to make sure that either there's regular periods or some medication to protect the lining of the uterus, and looking for anxiety and depression and those things. So there's also just a couple of good resources that I wanted to mention just before we finish. So there's a really good, out of Monash University in Australia, this is where there's Australian-led international PCOS guidelines published in 2018, and there's a lot of really good resources on that website. There's an app called the Ask PCOS app. It's all linked with all of this. There's really good patient and GP resources on that website, really good video clips and interviews with patients and various health professionals. And there's a lot of good information there, and I would strongly recommend that. There's also the Jean Hales Foundation, which is also Australian. The Australians get a lot better funding for all of these things. Their website is really good. That has a lot of really good women's health stuff on it, and it has some really good information about PCOS. So they're good sort of trustworthy sources of information. So I think now we're ready to move on to the questions. I do have two that got sent through today that I will answer first, and then the other questions are going to come through so that we can go through them. So one question that came through today was about tracking and confirming ovulation. And, this person said, I know a lot of women say that ovulation predictor kits are unreliable when you have PCOS. What else would I recommend for tracking ovulation for those with PCOS? And this person says they're trying to conceive, but it's a nightmare trying to work out whether they're ovulating. So I guess what I'd say is, look, if somebody's having regular periods every month, even if it's every 5 or 6 weeks, then they probably are ovulating. And ovulation should be happening 2 weeks before the period arrives. So if a cycle's 5 or 6 weeks long, then ovulation is going to occur later. It might not be occurring till roughly day 21 or roughly day 28 of the cycle. So that's when you want to concentrate your efforts on trying around that time. ovulation kits can be useful. They can be useful to reassure people that they are ovulating. When they get a positive, they can think, oh yes, I'm ovulating, and try. But it's really important that they've tried in the few days before that, because you know, on the day that the ovulation kit is positive, it might be almost too late to try. So if you can say, well, look, that's good, and I know I tried yesterday or the day before, well, then that would be reassuring. But if you've got long cycles and there's no predictability to when the periods are going to come, then I think probably trying to use ovulation kits is a bit of a waste of time, and it would be more sensible to come and see us and get started on some treatment to make the periods more regular. That would be more useful. Otherwise, you know, you could be doing ovulation kits for 2-3 weeks on end. So, you know, once periods are regular, then they should be more useful. The other question was, what would be the recommended tests for couples trying to conceive? So, you know, if a couple's tried to conceive for 6-12 months and hasn't been successful, then the recommended tests, you know, either if someone comes to see us or they may go to their GP for some initial testing. You know, there's usually a blood test on day 2 or day 3 to look at the FSH hormone levels. You know, maybe one after ovulation to confirm that ovulation's occurring, looking at the progesterone level. It's usually also a chance to check a whole lot of basic blood tests like a blood count, check the thyroid gland, check that people are immune to rubella, all of those things. So there's sort of a series of pre-pregnancy blood tests. And for the man, the main test is, of course, the semen sample, getting a semen sample off to the lab, checking that there's a reasonable number of sperm, reasonable motility, and that there isn't, you know, a really obvious male problem going on. So they're the sort of initial tests that a GP or somebody would do initially. If you come along to see us, we would often do a pelvic ultrasound scan at the time of the visit as well, if it's appropriate, or arrange for a scan to be done, and maybe testing of the fallopian tubes as well after the visit. Now we've got a question here. Why is IUI not listed in the slideshow as a fertility treatment? So IUI is intrauterine insemination, or some people call it artificial insemination. It's a very valid fertility treatment, and just the only reason I haven't popped it in is that it's not really a treatment for polycystic ovary syndrome. So, you know, if people aren't ovulating regularly, it's all about treatment to get them to ovulate regularly, and usually if the sperm's good, they should then be able to you know, to try for pregnancy naturally at home. There will be some people where maybe the sperm count's a little bit reduced, where some IUI cycles might help, or if they've been ovulating on treatment like Letrozole but haven't got pregnant, they might want to do a few IUI cycles to try and increase the chances a bit further before they look at IVF. So it will sometimes be used, but it's not considered one of the main treatments for PCOS. Another question here, what are my thoughts on inositol? So inositol's a treatment that people can get on the internet or via a health food shop, and it can, you know, I'm not an expert on it. There's a lot of various, you know, things out there, but sometimes that can improve the symptoms of polycystic ovary syndrome and perhaps make people a little bit more likely to ovulate. But it's not, you know, it's not going to be as successful as taking Letrozole or something like that. But it may, you know, it may have benefits for some people. But I don't think we've got enough evidence to know exactly what dose people should take, all of those things, and things like that come in as food supplements. It's a little bit difficult because they're not controlled in the same way as medication. So we can't be 100% certain exactly what's in some of them, just because it says on the bottle that it's got this or that at this dose. It's not actually tested in the same way that a medication is. So we'll just always have to be a little bit cautious about that. So, yeah, someone says here, if someone's taking Primolute, which is a progesterone to regulate the period or cycle for 2 weeks on and then 2 weeks off, would they still be able to take Letrozole when the period arrives? Yes, they would, but then we wouldn't want them taking the Primolute. So we'd want them to, you know, take the Primolute, get the period, and then take the Letrozole, and then we'd want to you know, monitor the cycle and make sure that they respond to the Letrozole, and hopefully they then ovulate. That will give them their own progesterone and either become pregnant, or if not, at least have a period. Do women with PCOS produce more abnormal eggs? Our first child conceived naturally has Down syndrome. His birth has been followed by 3 first trimester, so 3 early miscarriages, including 1 caused by trisomy 15, so an extra copy of chromosome 15, and we've been using letrozole for ovulation induction. Does this increase the risk of abnormal pregnancies? The answer is no. You know, obviously you've had a pretty rough time and that sounds terrible, but there's no clear evidence that, or there is no evidence that ovulation induction, all it's doing is getting you to ovulate and use your own eggs. So there's no evidence that there's any increase in the risk of babies with abnormalities. You know, I would assume with that story that you and your partner have had your carrier types checked to make sure that you both have the correct number of chromosomes and aren't at any increased risk of having miscarriages or things relating to that. And, you know, there are some other investigations and treatments that can be looked at for recurrent miscarriage, but no, it's not caused by the letrozole, and it's not caused by, you know, having PCOS and needing ovulation induction. So someone else has said, if you have a high AMH reading, more than 70 picomoles per litre, so that is quite high, is that likely due to PCOS, or is there a different reason why the reading might be high? So that is most likely associated with the PCOS. So women with polycystic ovaries do have much higher, on the whole, have much higher anti-Müllerian hormone levels. Anti-Müllerian hormone is the hormone produced by little immature eggs at a certain stage of development in the ovaries. So the hormone level gives us an idea as to whether people have got lots of eggs remaining in their ovaries for age, or whether they've got lower numbers for age. And, you know, high numbers of eggs is absolutely what polycystic ovary syndrome is about for a lot of women. So almost certainly it's related to that. The report will sometimes say, you know, high level, think about other things. Very occasionally you can have a little tumour or growth in the ovary producing high levels of anti-Müllerian hormone, but that's quite unusual. And for most people it will be related to polycystic ovary syndrome. So someone else has said, when would you recommend going to a fertility clinic? You know, 12 months after diagnosis of PCOS, or 12 months after first period has finally come. I would say, you know, sooner rather than later. If somebody's got PCOS, or even if they don't know whether they do or don't, but if they're not having regular periods or not having periods at all, they do not need to wait a year to come and see us. You know, if it's very clear that there's a problem if you're not having regular periods, and, you know, coming and seeing us and getting that sorted out is sensible, you know, not waiting just because you meant to wait a year before you go along. You know, if a period has come after taking metformin, well, that's good. But, you know, if you want to, you could wait and see if some more regular periods follow. But, you know, I would suggest, unless you suddenly start getting regular periods, that you don't wait too long. So next, yeah, so someone said even with irregular periods, how often should they have sex if they're trying to get pregnant? And it's hard to track. It is. If your periods aren't regular, it's very hard to track a cycle, and you know, will be difficult. You know, but having said that, if you are having irregular periods, you may well still be ovulating, just quite infrequently. So if you want to try and make sure that you do still have the opportunity to become pregnant, then, you know, perhaps every couple of days, maybe 3 times a week. You know, good sperm should be able to fertilize an egg 2-3 days after they arrive. So, you know, 3 times a week would be fine, but, you know, yes, getting seen and getting ovulation to occur more regularly should make things a lot easier. So, okay, somebody said here they've had 2 laparoscopic surgeries and now going through IVF, 3 unsuccessful embryo transfers. Should they have another laparoscopy? Look, you know, without knowing more details about what the laparoscopy was for, all of those things, it's really difficult to say. Women often who've had a number of laparoscopies, it often might be because they have endometriosis. And there's, if people do have endometriosis, then yes, it's good to get a diagnosis, it's good to treat it. But if somebody's, had endometriosis treated and removed, it can sometimes be a difficult question, when should they have another laparoscopy? And the main guideline would be symptoms. So if they've got more pain and having a lot more symptoms, then that's probably a good time to be thinking about another laparoscopy. But if treatment isn't working, there often comes the question, should you have another laparoscopy and see if treating any endometriosis would help? And that's sometimes a tricky question to answer and is debated back and forth a lot. When would your checking your fallopian tubes be indicated? So really, as in the setting of polycystic ovary syndrome, and people perhaps coming along in the first place not having regular periods, then if there's something in the history and what they tell us that suggests that they may have had a nasty chlamydia infection in the past or a nasty ruptured appendix, something that would make us more suspicious about fallopian tube damage, then we may suggest that at the beginning. But if there's nothing like that, then we might often suggest that we get ovulation to occur regularly, and if pregnancy hasn't occurred over 3 or 4 cycles, that we check the fallopian tube then. If people come along having had regular periods already and tried for a year or more, then we may well check the fallopian tubes much earlier. Having the fallopian tubes checked isn't the most pleasant thing. Some fluid or dye needs to be injected up through the cervix. It can be quite uncomfortable at that point. So, for someone who hasn't been ovulating and hasn't had much chance to get pregnant, it often seems more sensible to get them to ovulate a few times before we send them off for that test. Right, so it looks like time is nearly up. So, Nicola's said not too many more questions, but there's one here that I can answer before we're done. Someone's saying, how many rounds on clomiphene should they do before they ask for letrozole? Well, look, as I said, for the last, quite a few years now, letrozole is the international recommended first-line treatment for ovulation induction for polycystic ovary syndrome. So letrozole is really what should be prescribed. Some GPs will hand out clomiphene, and there probably are some gynecologists around who still, they're used to prescribing clomiphene. So, and their pregnancies will still happen on clomiphene, but I would say, no more than 3 to 6, and I would be looking at taking letrozole because it does have a number of advantages and better chance of pregnancy. And then here we've got about using the contraceptive pill. Look, the contraceptive pill absolutely is a really good treatment for polycystic ovary syndrome. And, does help with a lot of, as well as just regulating periods, it will often improve skin, acne, hairiness, a whole lot of things. And, if a woman, there's lots of good reasons to go back on the pill. One of the things about the contraceptive pill, because there's a little bit of estrogen being given all the time, as well as progesterone, there is some concern that perhaps as women get older, into their 40s, that, there's an increased risk, perhaps a small increased risk of blood clots in the legs and lungs and a few things like that. So if you've got someone who's overweight, and has other risk factors that might also increase their risk, sometimes people will be a little bit reluctant to prescribe that for a long period of time and have somebody on it for a long time. There are other options though, things like having a Mirena in the uterus, which releases a little bit of progesterone all the time, and most women with that won't get periods. So there are a lot of other good options as well if it's decided in the end that there's perhaps too much risk from taking the contraceptive pill. And then someone said, is it common to have severe pain when periods begin with PCOS? Now, look, that's one of the other myths about PCOS. PCOS doesn't cause pain. So quite often women with painful periods are told that it's because they've got PCOS. There is no good evidence for that. There's lots of reasons for, a number of reasons for having pain when periods start or with periods. If the bleeding's really heavy, then often, then pain and heaviness go together. Some women will have endometriosis, and that's something that may need to be looked for you know, as well. So other things ideally should be looked for in that situation. Someone said, so a high anti-Müllerian hormone reading won't give you an accurate reading if you have PCOS. No, with PCOS, you'll still get an accurate, the anti-Müllerian hormone testing is accurate, but we do expect the level to be high. You know, they go hand in hand, and we wouldn't be concerned about that. You know, on a positive front, it means that you've got, if the level's high, it means you've got lots of eggs for your age, and you don't need to be worried about running out of eggs early and having difficulty getting pregnant because of not enough eggs, which will happen to some people. And then someone said, you know, on a similar vein, does PCOS impact on the expected age of menopause and subsequently the window of fertility? And the answer is yes. So women with PCOS and high anti-Müllerian hormone levels are actually likely to go through the menopause later than average and may have a slightly longer window of fertility. So the women with the highest anti-Müllerian hormone levels are often the ones who may become pregnant a bit more easily in their early 40s, when other people are often running out of eggs and finding it quite challenging to become pregnant. It is, however, the age of the eggs, which is basically your age, which is the most important factor, but AMH and egg number do play a part. And then someone said, is it possible to develop PCOS due to being on the pill for more than a decade and then coming off it? No. So the contraceptive pill does not cause PCOS. You know, if your periods are irregular and you have symptoms, you know, consistent with PCOS after coming off the pill, it's not because you were on the pill. Some people may have had those symptoms before they went on the pill and they've forgotten that, and that was part of the reason they went on it. Others, you know, when you talk to them, you may find that actually they're 10, 15 kilos heavier than what they were when they were younger. And there's been other things that have changed that have then meant that those PCOS type symptoms have come out, and it's not the actual contraceptive pill that's done that. Right. And then we've got women with PCOS tend to have higher miscarriage rate, and is there anything you can do on an IVF cycle to reduce this? Well, look, that's actually debatable. Some studies have suggested that, but a lot of other studies have not suggested that. We know that women who are overweight have a higher miscarriage rate, and so it's trying to tease out, is it just being overweight, or is it having polycystic ovary syndrome? And at this stage, the evidence is probably more that it's increased body weight rather than PCOS. On an IVF cycle, women are given extra progesterone anyway to reduce the risk of miscarriage, and there are some extra things if people are worried. There are some extra types of progesterone that you can take if people have had miscarriages before, sometimes low-dose aspirin, so there are a few things that you can do, but we do still see miscarriages with IVF treatment, just as we would expect, you know, similar rate that we would expect for women, you know, of any age. And then, so if you've been diagnosed with PCOS but are now having regular periods, could you still not be ovulating? Usually, if you have regular periods, you will be ovulating. You know, that can be proven by doing some progesterone hormone levels. But, you know, people don't have a period every month if they're not ovulating, well, unless they're taking the contraceptive pill or something to cause a period every month. But yeah, you know, and you know, that's good if that's the case, that somebody's having regular periods, because if they're trying to become pregnant, hopefully that may happen without too much trouble. All right, it looks like we have run out of time, so thank you.
We have. So thank you so much, Dr. Wakeman, for tonight's session, which was incredibly informing. So thank you very much for doing that for us. That's Dr. Sarah Wakeman from Fertility Associates in Christchurch. And thank you to everybody who's joined us this evening for spending your time, and also for your excellent questions. Right. So thank you so much, everybody. Take care and good night.
Good night. Thank you.